Thank you. Hi, welcome to my presentation. For those who don't know me well yet, I was working in the General Hospital Kuala Lumpur for about 10 years, and now I'm mostly based in Kuching. My task today is to talk to you about the topic of approach to wetting, including neuropathic bladder and voiding dysfunction. In fact, I'm going to talk mostly about urodynamics and neuropathic bladder. I will not be talking about enuresis. I'm very blessed to have wonderful colleagues and patient parents because I'm going to talk about my experience in this topic, and hope you will like my presentation. It is a misconception that urodynamics answer all the questions. It's like a magic bullet. Another misconception is that urodynamic is very difficult, especially if you have a patient or a case during the professional exam. But nevertheless, urodynamic is invasive. So what I'm going to do is I'm going to talk about urodynamic in a simple manner, and I will share real life experiences in such a way that we can all remember. So we start with the non-invasive urodynamics. Like any other medical condition, we start with the history. In fact, the bladder diary is supposed to be the first urodynamic test. Then we do a physical examination focusing on the problem. Then we do the laboratory tests. Of importance is the kidney function, the serum creatinine, the urinalysis, the urine culture, and then the imaging. The mainstay imaging is ultrasound. Very occasionally, we do an MRU. And then we do uroflowmetry and bladder scan. So this is the non-invasive urodynamic, which people often forget. Then we go to the invasive urodynamics, feeling cystometry, where we have to actually put catheters into the patient. Often followed by voiding cystometry, if we can get the patient to void. And the gold standard is a video urodynamics, which is not available in most hospitals. And finally, the specialized urodynamics, like the urethral pressure profile, where we measure the EMG, usually with surface electrodes, etc., etc. So I'm not going to cover this. If you attend a full urodynamic course, example, those sponsored by Library or sponsored from the Bristol Urodynamic Institute, you can have a 2-day lecture on all these more refined parts of urodynamics. Now, obviously, neurology is very important, and it's often thought that if you know the neurology, you can come to a urodynamic diagnosis, but it's often not true because the neurological lesion is a mixed lesion, and the neurologic lesion may progress over time. So just to put in brief, what are the neurological lesions that can affect urinary function? The nerve supply to the bladder consists of the autonomic, which are the sympathetic to the hypogastric nerve, and the parasympathetic, which goes to the pelvic nerve, mainly the pudendal nerve. And the pudendal nerve have a dual supply, the other supply being the somatic supply. Then this goes to the sacral, S234, and goes up the spinal cord to the pontine area, the micturition center, and finally to the brain. So any disturbance of any part of the urinary tract can affect the voiding function and dysfunction. Now, what about terminology? The terminology have changed a lot over the years. I will not go into a lot of detail, save to mention the important definition of dysfunctional voiding, which actually is a spectrum of symptoms where during voiding, there is an involuntary contraction of the pelvic floor, and these patients do not have a neurological cause, unlike patients with spina bifida. And if the patient can still void, the voiding pattern tends to be of staccato voiding pattern. And in severe cases, even the patient has no neurological lesion, they can end up with bowel emptying, incontinence, recurrent UTI, and even renal failure. And this is often referred to as the Kingman-Allen syndrome. I will give you the references to this terminology at the end of the lecture. Now, what are the causes of a neuropathic bladder? We all know the commonest cause is spina bifida. We also know that the posterior atrial valve or PUV is very common. And thirdly, the dysfunctional voiding. And in many places like in Sarawak, we have still got infection of the spinal cord, transverse myelitis, tuberculosis. We have the occasional spinal tumor. We have the occasional trauma in children. We also have the occasional vascular malformation. In fact, I have all these patients in my follow-up in my current practice. This publication from BJU in 1998 points to the importance of the central nervous lesion to fetal abnormality. So we all know that PUV is an important contributor to neuropathic bladder, but actually, in actual fact, neuropathic bladder is much commoner. Okay, so this is the neuropathic bladder. This is very common. This is very common. This neuropathic bladder is very obvious. But what is less obvious, maybe just a dimple. And if you do further investigations like an ultrasound, or you do an MRI or a CT scan, then you get more detail. And another type of lesion is called a tether cord. That means the cord is down in the beyond L1 seen on MRI. But not all the tether cord require operation. So the spinal canal, the spinal cord is very important to the lower limb as well, in addition to the neuropathic bladder. Now, my good friend Dr. Hussein Iman, who was the previous chief of pediatrics, who said that you should add fluoride to all the rice in Malaysia. Then we have much less spinal bifida. But I think we're still seeing an increasing number of spinal bifida in Malaysia. We started the first spinal bifida clinic in the National Hospital in 1994. And at that time, we have a pediatric neurologist to come and join us from UKM. Now I heard that we have the developmental pediatrics. In fact, in our local general hospital, we finally have a resident pediatric nephrologist, and she's also going to start a spinal bifida clinic with input from the developmental neurologists, and of course, hopefully, we still have input from the urologists. Another way the patients can come in children is fever, like just non-specific fever, and found to have UTI. The biggest children will have complaint of urinary frequency, incontinence, and some other enuresis. And also, as an adult urologist, I do see patients who come pre and post-op because of medical legal documentation. What are the aims of urogenic bladder treatment? This is a slide from my lecture when I first give this lecture in 2008. And I think basically it's still the same. The first function is to preserve renal function, to prevent hydronephrosis, to prevent high bladder pressures. The pressure, well, 30 is safe, 40 is very dangerous. And of course, for the bigger children, we want them to be continent. The incontinence may be due to hyperreflexia, may be due to poor emptying, overflow incontinence, may be due to sphincter weakness. And of course, we do not want them to have UTI, especially febrile UTIs. And of course, there are many other factors in the overall care of the child, constipation, the orthopedics, the club feet, the skin, the neurology, and of course, some of them also have psychological concerns. So in the assessment of such patients, I'm very pleased that there's a move now to involve the GP, especially to look after the adolescents. In fact, any doctor can assess these patients, because basically you need to know the symptoms, the UTIs, check the continence, check for constipation, check the lower limbs, check for neurology, examine the patient, examine the back, examine the legs, look at the diapers. We do the urinalysis, the urine culture, look at the creatinine. So if any of these give a clue, then we must keep thinking of the neuropathic bladder. And of course, they will manage the patient and onward referral to the neurologist or to the urologist. The most important investigation is the ultrasound. And it's not just a simple ultrasound. It's a specific ultrasound. When you ultrasound the kidneys, you look for the bipolar length, you look for the parenchymal thickness, you look for the AP diameter, anterior posterior diameter, look at the ureters, and you look at the bladder. You must not just say bladder is underfilled. You must look specifically for the bladder volume, look for the bladder wall thickness, look for the post-maturation volume, look at the bladder neck, and look at the posterior urethra. So you form a group with these pediatric uro radiologists. Okay, so these are the basic things which any doctor, in fact, we should encourage all the doctors to look for this these abnormalities and to refer them onward thereafter. What about if the patient comes to the hospital, either under the urologist or the pediatric surgeon or the pediatric nephrologist? Then they have further imaging, usually a MEC3 imaging. I think most hospitals, even in the local general hospital, they do MEC3. And although MCUG is less done nowadays, I think they're still needed for neuropathic bladders. And of course, finally, the urodynamic study, the vital urodynamic study. The first component of urodynamic study is a feeding cystometry. The question is, when do we do it? I think, to be realistic, we do it at first contact. So usually that may mean 3 months. If you are too small, then we are worried about the catheter size. We may have to put a suprapubic catheter, and then we repeat it at 2 years. But if at first urodynamics, or due to other suspicion like renal impairment, hydronephrosis, we think it's a hostile bladder, we may do it more often. Otherwise, we can repeat it every 2 years. But I think this part is grossly undermanaged in Malaysia. So this is the ultrasound. I think the ultrasound is the most useful adjunct to urodynamics in Malaysia. So this shows the typical Mickey Mouse appearance, where there is hydronephrosis. And this is the bladder. The bladder, you measure the bladder wall thickness, diverticulum, trabeculation, residual urine. And I show you a few cases. This is a young adult who saw me in GHKL. This is 1994. I was still in GHKL. So this is in those days we still do the IDU to assess the renal function and the drainage. And this is just a normal IVU. After 2 years, this patient went into bilateral gross hydronephrosis, trabecular bladder. Another patient. This patient was already diagnosed as spinal bifida at birth, operated by a neurosurgeon at birth, and has a regular pediatrician, regular community pediatrician. And finally, at the age of 10 years, she was admitted with high fever, found to have UTI, gross hydronephrosis. And finally, I did a cystoplasty on her at the age of 12 years. And she's now a pharmacist, but of course, she's a CKD. So this is the trabecular bladder, diverticulum, circulation, hydronephrosis. So we are still missing this. I think it's still happening now at in many localities in Malaysia. This is another patient referred to me from a hospital university, and they asked me to do a cystoplasty because the patient's creatinine is already 400. It's 400, and there's bilateral hydronephrosis. They never mentioned in the referral letter this condition. This patient has got bed sores, and not only bed sores, the bed sores are deep and have osteomyelitis. So this is very, very unfortunate. So we must try to avert this kind of condition. So what is urodynamics? Urodynamics is the evaluation of function and dysfunction of the bladder, okay, and the sphincters. And it also includes the upper urinary tract. Although I won't talk much about it, we don't mention much about it. But in the first Malaysian Urological Conference in 1991, we got Dr. Robert Whittaker, and he demonstrated the Whittaker's test, which is the assessment of the upper urinary tract urodynamics. Of course, in children less than 4 years of age, it's not easy to interpret urodynamics because they already have involuntary contractions. Now I go into the bread and butter of urodynamics. Now the first assessment, of course, is to do a uroflowmetry, and it's a free flow uroflowmetry. You can do it separate from the urodynamic study itself. Now, unfortunately, there are many confounding factors to doing uroflowmetry. First, that they must have some privacy. The environment must be conducive, and not only that, nowadays, with all the instrumentation, there are 2 types of uroflowmetry. The power supply can be from the main electric supply, can be from the battery. Make sure the battery you have a good battery, and some of them are connected by Wi-Fi. So make sure that the Wi-Fi environment is suitable. So this is the first thing, to have the appropriate hardware. The next concern is regarding the environment. This is my uroflowmetry, which I've been using for about 20 years. This is in a big toilet, and this is the nearby toilet bowl where the patient can clean and wash himself, and can even pass motion if he likes after the uroflowmetry, or he can pass motion before the uroflowmetry. I didn't show here, there is another commode here for females and for children. Now, some people do not realize that actually you require a conducive environment to do uroflowmetry and urodynamics. Okay, so this is a toilet in one of the famous universities. outside here is the main road, so nobody passes urine there. This is one of the famous hotels. It's open space, like open space approach, you know. So I think also not very popular. So here's another 3-star hotel. They put partition, and of course nowadays you go to all the toilets, they have what is it called? Social distancing. So not very conducive to pass urine. I borrowed this chart from Professor Stephen Yang, and it shows that a girl doing uroflowmetry in this uncomfortable position with no foot support, and then with foot support, the uroflow pattern have improved tremendously. This some of my other collection. This is a young adult who have got constipation. So before we clear his bowel. This is his uroflowmetry. This is after we clear his bowel with enema. Okay, so this is the patient who has got intermittent flow rate, intermittent, more like dysfunctional voiding. This is also like dysfunctional voiding. I show you more patterns. So this patient has got this kind of pattern, and it's supposed to be an underactive bladder. This is supposed to be an obstructive flow pattern. This is supposed to be a dysfunctional flow pattern, and this is supposed to be an overactive bladder or hyperreflexive flow pattern. So there are many types of flow pattern, and even the urine flow rate depends as well on the age. I think the normal age, the normal flow is supposed to be 15, but in children we can accept a bit lower, maybe 10 or 11.5. Now, in many centers, including in Malaysia, most of the time the urodynamic is done by a technician, mind you, a trained technician, and I think we can't change that really, but I think the doctor must have a more active role in preparing the patient for the urodynamics, so that you know what you're looking for, and ideally should be present during the urodynamics. When I was doing my overseas attachment, we have a urodynamic meeting every Friday afternoon, whereby the urodynamic technician, the radiographer, the consultant, and the senior registrars will sit together and review all the urodynamic tracings and the videos. So you have to pay attention to this, because otherwise you don't get a full result from the invasive urodynamics. This is the setup in our local hospital, local general hospital. This is the only new thing. The rest is still old, and you can see this is a metallic bed. Although the wall is plastered for radiation protection, we can't really move in a Siam to do a video urodynamics in this particular setup. This is the urethral pressure profile puller, okay. So this is my setup, my traditional setup, whereby we put in 3 catheters. Basically, I use three feeding tubes, 6 French feeding tubes, 2 into the bladder and 1 into the rectum. And this is water filled, not air charge, water filled, connected to a 3-way tap to flush out all the air bubbles and to be zero to the symphysis pubis, and is filled by fluid. Usually we use room temperature saline. We can fill it from 2, 5, 10, 50, 100, depending on the bladder capacity and depending on what you're looking for. The rectal line, we can use the finger stole, but you have to make a small hole there so that you can flush out the air as well. And in very small children, sometimes we have to put a super big catheter so that it doesn't block the urethra when you're doing urodynamics. In small children, we put a super big catheter using a big trocar, a big granula, and put in a small feeding tube. So this is my system. This is my system. Nowadays, usually we use a dual lumen into the bladder and this into the rectum. This costs quite a lot of money and is connected to the transducer, which is a charge. This is a charge. The catheter tip transducers are very expensive. Now, what are the problems with urodynamics? First, in a child, it's very frightening. So sometimes you may have to sedate them a little, but I think it's probably better to be child-friendly and allow a carer to be in the room. If there's gross reflux, the urodynamic will not be accurate. And if they have a high residual volume, you're not supposed to empty the bladder. But at the end of urodynamics, you must empty the bladder. And of course, there's a risk of introducing infection. And I think it is wise to give a single dose antibiotic. It can reduce the significant bacteria rate if you give them a single dose antibiotics. Good renal function, you can give them a small dose of gentamicin or ampicillin or augmentin. Now, is urodynamic lethal? Can you kill the patient? I think we all know. I think the urologists will know that if the patient has a third quadriplegia, they have a high spinal lesion, they can get severe autonomic reflexia and severe hypertension, and they can have a stroke. So the treatment is you either give them a sublingual adrenaline beforehand, or the moment you feel that the patient says he's having a headache, you stop the procedure immediately. Okay. Even if you use an anesthetic, they can still get severe hyperreflexia. And in some Caucasian children, they have a allergic to latex. So you make sure that you don't use any rubber content in any of the catheters, because they can have anaphylactic shock. And of course, try not to inject Happy-Can lotion when you inject any anesthetic, any cream into the patient. This was the urodynamic that I used way back in 1985. It's really real time. It's a hot drum. And this was the urodynamic setup that I was using before I left GHKL around 1996. So this is not video urodynamics, but it's basic enough. This kind of urodynamic setup is basic enough for solo private practice. So that you can do uroflowmetry, you can do feeding cystometry, you can do a good voiding cystometry, but you can't do video urodynamics in this kind of setup. And even this setup is quite costly. I think most urological centers where there is a urologist should have at least this kind of setup, where there is a uroflowmetry, where there is a cystometric setup to measure the pressure, where there is arrangement for the patient to do voiding cystometry. This is in the National Referral Center. I think I got this picture from Miss Susan Wu, whereby they have a C-arm, they have fluoroscopy, they have recording. So this is the state of the art, and often, of course, it's still done by sometimes done by the radiographer, sometimes done by the urodynamic nurse, and sometimes, of course, you can have male and female urodynamic nurse. So this is the technique of video urodynamics. Everything is the same except that there is synchronous recording and fluoroscopy. So during the time you can look at reflux, you can look at the bladder neck, you can look at the external sphincter, you can record all this. So you give a complete picture of the voiding process. So of course there's radiation. So you have to practice radiation control to have a lowest radiation possible. So you can measure the bladder pressure, measure the flow rate, you measure the voiding cystometry, and if you need to, you can also put surface electrodes and measure the sphincter EMG. Now we talk a little bit about the management approach to the types of neurogenic or neuropathic bladder. We are not so concerned about the low pressure systems. We are worried about the high pressure system, because this can lead down to renal failure. And high pressure, by definition, I think is 40. 40 is really high pressure. 35 is also high. 30 is better. And if it's a low pressure system, if the patient has got a good sphincter, the treatment basically is intermittent catheterization, either by the patient or by the carer. If the patient has a weak sphincter, then they have to wear incontinence pads. And when a child is big enough, you can consider artificial urinary sphincter. But unfortunately in life, we often have intermediate group. Okay, they are neither high pressure nor low pressure, or they are progressive. They change over time. So it's often not just black and white. The other important parameter to know is regarding the bladder volume. The post-void residue in children should be less than 20 mils. And I like to use the formula: the bladder volume of a child is the age plus 2 in ounce. And of course, 1 ounce is the disease. Of course, there are many other formulas that you can use. So this is the simple urodynamics. Urodynamics made simple. So when the bladder is filled by urine, during urodynamics, the pressure is very low. Okay, 5, definitely less than 10. And then when the patient passes urine, there is a detrusor pressure. Again, this pressure is below a certain value, the voiding pressure, usually less than, depending on the patient and of course the sex, whether male or female. So if you have a patient whose baseline pressure keeps going up, what's called the poor compliance bladder, this is unsafe. The patient will almost always get renal failure. Whereas if this patient has a good baseline, intermittently they have an unstable contraction and comes back to baseline, this is relatively safer, but you have to look out. They can turn into poor compliance. What about pressure flow? Pressure flow basically depends on the pressure when the patient is passing urine, and most of the urodynamic machines will come with a graph for you, a nomogram for you to fill in, or you can use the formula to fill in a nomogram. So if I have a high voiding pressure, this one is 100, obviously obstructed. Okay, so if this patient goes for surgery, that you expect the pressure to be down. Okay, the voiding pressure drops. If you go for surgery, this will be indication for surgery for the patient, not so much for medical therapy. We're talking about BPH. So the voiding pressures should be less than 68. Girls is lower. Girls are lower. Okay, I think more or less the same for male and female adults. Now, the last 5 years, we have recognized that there is a thing called low pressure, low flow. In fact, I know this for a long time. I know because there are a lot of young people who have low pressure and low uroflow. So don't do an operation on the bladder neck or on the external sphincter for these patients. So these patients have a primary impairment of detrusor contractility. So they have low pressure, low flow voiding, and not obstructed. Okay, not obstructed. So these patients are not associated with uterine obstruction. So no matter how many QRP you do for them, how many bladder neck incision you do for them, how many dilatation you do for them, they are not going to have a better uroflow. Okay, these patients are there, and even in pediatric patients. Now, if you can get the child to void or you get the patient to void, you can do a voiding cystometry. So you see the voiding pressure is 24, it's very low. Okay, voidal volume 325, peak flow is 12. So this to me is an almost normal uroflowmetry. Now, why don't we say we do one uroflow, one urodynamics, and we forget about the patient? But this publication shows that over time, there's a tendency for patients with neuropathic bladder to progress, but not all of them progress, and some of them can improve. Another important parameter is called the detrusor leak point pressure. In other words, the pressure in the bladder, the detrusor bladder in the bladder, that when the patient will leak. And according to Edward McGuire, he defined in 1981, if it is more than 40, there's a high chance of the patient developing upper tract deterioration. And you can get this pressure by asking the patient to cough or to do a Valsalva maneuver, and we do it in adults at the pressure of 200 to 300. Okay, now we talk about dysfunctional voiding. It's something actually quite difficult to diagnose. This is my classical picture of a sphincter dysanesia. So when the patient is supposed to be passing urine, the external sphincter is contracted. Okay, it's contracted, and they have no neurology. This non-neurogenic bladder. How do we treat these patients? I think the favorite treatment is biofeedback, but biofeedback is not so easily available. I don't know whether it's available in IUN care already or not. Some people give the alpha blocker. I'm not sure whether it works or not. An alpha blocker that I've given is terazosin, 0.5 to 1 milligram. I think other measures like time voiding, behavior therapy may help the patient. Some of them may be associated with bladder bowel dysfunction. So these patients, when they are voiding, they have an EMG activity. So the sphincter contracts when they are voiding. Okay, because they're interrupted. So how do we treat high bladder pressures? One way is to give them an anticholinergic. The classical one, of course, is oxybutynin. You can give it intravesical as well. I don't know about beta-3 agonists. I haven't used them in children. Of course, it will definitely be off-label. Other important measures like avoiding constipation, physiotherapy, and finally, of course, surgery, urological surgery. And the urological surgery is a cystoplasty, and the one that's classically done is a clamp cystoplasty. I will elaborate a little bit more on that. What about the role of antibiotics? Nowadays, in the latest publication in July 2021 in the Journal of Urology, now they find that actually you do not need to give antibiotics to everybody. And I circulated it in the SIG group for pediatric urology in Asia Pacific, and most of us agree that we should reduce the usage of antibiotic prophylaxis in pediatric urology. What about oxybutynin? This is a very old study, but I think the current studies still indicate the same thing. if you give them early oxybutynin to patients, even if they are on a catheter, the chance of developing hydronephrosis is much less, 3% compared to 23%. So I think there's a move, well, that's been there for a long time, to start patients early on oxybutynin. Oxybutynin is quite cheap, right? It's still available, and I think there's no cognitive problem with oxybutynin in children. The other mainstay treatment for neuropathic bladders is intermittent catheterization by the patient or by the carer, and up to 50% of patients will require intermittent catheterization. So this is a very important topic. You must know about it. The nurses must know about it. The parents must know about it. And of course, nowadays we got videos, we got websites which can help them. The type of catheter to use, when to use, what volume to use. So CISC is a very important treatment for neuropathic bladders. Okay. Never use the Foley's. The Foley's, the catheter volume is very small. So you can, if you don't have the CISC catheter, you can use a feeding tube, a small feeding tube. The lumen is big. Try to avoid using rubber. And if the patient is very septic, socioeconomic is bad, you can't find somebody to do CIC, I still think it is not a bad idea to do a vesicostomy. I don't put a Foley's catheter. This is to calibrate it to 20 French. And I think most surgeons can do a vesicostomy. Okay, most surgeons can do a vesicostomy for whatever the underlying cause. The posterior atrial neuropathic bladder. I have done vesicostomy for neuropathic bladder as well for my personal experience. Okay. In the journal of urology, they said that 5% of spinal bifida, this published not so long ago, 2011, have a vesicostomy done. So it's not that bad, not that bad. Of course, if you have the surgical expertise and the child is fit and you cannot catheterize the patient from below, then you have to do a catheterizable channel. And 11%, according to this study, 11% of spinal bifida actually go for that. Usually we use the appendix. I think pediatric urologists, pediatric surgeons, adult urologists who have an interest in pediatric urology should be able to do metrophenol using the appendix. Not a very difficult operation. Now, how do we lower the bladder pressure? Long ago, it's quite fashionable to do sphincterotomy, but I think it's more reliable to do a cystoplasty. And again, 10% of spinal bifida patients undergo a cystoplasty. This is my favorite slide. So it's called clamp cystoplasty, where we bypass the bladder up to the trigone, protect the urethric orifice with feeding tubes, and take a segment of the ileum and put it down. So it's called clamp cystoplasty. In the review of cases we had, which we published in one of the MUCs, 14 of the 65 cases in that study period had a clamp cystoplasty. And sometimes if we think that the ureter is obstructed at the UVJ, we also reimplant the ureters, either direct implantation into the bladder, or we reimplant it into the intestine. Okay, if the bladder is too thick, we reimplant into the gut, because sometimes there is obstruction at the UVJ. So doing a cystoplasty per se does not relieve the obstruction. Occasionally, we use other parts. I have used the sigmoid before because it happens to be nearby. Some people use the ureter. Some people may always mention about using the stomach, but I have never used the stomach before. So this is reimplanting the ureter. This is one of my cases, reimplant the ureter into the sigmoid, and this is how it looks like. This is the cystogram done after the cystoplasty. So what are the indications for cystoplasty in that published group, which we published in one of the AUCs? I think we published this in 1997, in one of the AUCs. Hydronephrosis, urinary incontinence, recurrent UTI, and quite often, frankly speaking, pre-transplant. Because if you transplant into a bad bladder, the kidney is going to fail. So we have done this pre-transplant as well. What are the complications? Cystoplasty is actually not without complications. Bear in mind that we have got two anastomosis, even three: the gut, the bladder, and the ureter. So one patient had the gangrenous gut. Some of them got mucus retention. Some got urine leak, fecal leak, gut necrosis. So actually, this procedure can have significant complications. So the child must be well enough to undergo the operation. What about you follow up the cystoplasty? One such patient I follow up for many years. So he had a cystoplasty when the creatinine is 300. And it is a mistaken belief that you do a cystoplasty, you can reverse the renal impairment. It does not reverse the renal impairment. In fact, the renal impairment can still progress. In fact, it will progress because the renal damage is already done. So this is one of my old studies now. This is another patient of mine where he has a cervical lesion. He has got a phasic kind of detrusor instability. If you leave it long enough, they may go into poor compliance as well. And then they will get renal impairment and bilateral hydronephrosis. Of course, the hydronephrosis will come and then renal impairment. Usually that is irreversible. So this is an unsafe bladder. We convert it into a safe bladder. Okay, this is post-clamp cystoplasty by me. We convert it to a safe bladder, but bear in mind, we still do not abolish all contractions. You cannot abolish all contractions, partly because even the gut is neuropathic, but you lower the pressure. Now, what about if you cannot do a cystoplasty for whatever reason? You don't have the expertise, the parents don't want. There are some other strategies you can do. Okay, you can protect the kidney. If the patient has a weak sphincter, don't put in artificial sphincter. Okay, unless they are willing to do cystoplasty and self-catheterization and for mucus washout. But at puberty, they may seem to improve. They become dry, but actually that's when the renal function will deteriorate. If the patient has got gross reflux, maybe you don't do an nephrectomy because they will take some pressure off the system. And if the patient's renal function is going off, you can do a thing called the night drainage. Because when the patient lie down at night, gravity no longer helps the urinary drainage. So the pressure builds up in the kidney. So they get a faster deterioration. So when you put these patients on night drainage, daytime you do CIC. Nighttime you leave the catheter in, you will find that the renal deterioration may be less. Okay, this has been documented, and especially Philip Ramsey, the previous pediatric urologist in Great Ormond Street, he strongly believes in this thing. And of course, you can do a more regular CIC, and if there's any problem with CIC, either the child is obese, the hands are no good, there's no carer, you can convert to a metophenol. And of course, finally now I think people are also using Botox to decrease. I think Botox is used in pediatric cases in Malaysia. And now I want to quote you a short study done by my colleagues on spinal bifida patients, which they published in the MUC, and they reviewed 65 patients from our neuropathic bladder clinic, a spinal bifida clinic, and they studied the patients, and 13 of them have a cystoplasty. And they analyzed the data. I will only show you the conclusion slide, which is very important. And the conclusion slide is that there are only two parameters which is important in terms of poor prognosis. And the most important one is constipation. So remember, when managing children with neuropathic bladders, remember the confounding factor of constipation. So that is my last slide. I think the borders are opening up. Please come to Sarawak for holiday, and I'll be happy to answer questions. Of course, I cannot give you the exam questions. We can discuss about what if you don't do urodynamics, or if it's not available. And these are the three most important references. In fact, the most important reference is from none other than from Miss Pungodi. She's part of the British Association of Pediatric Urologists Consensus Management, published in the Journal of Pediatric Urology. And these are the two important landmark documents giving you all the terminology of the words we use in urodynamics, in neuropathic bladders, how they change over the years and why they change the terms in urodynamics. Thank you for your attention. I'd be happy to take questions when I log in live, or we can do it on WhatsApp, we can do it on email. Thank you very much for your attention.